Good morning. Thank you so much for your patience. We are going to go ahead and get started today. Welcome. My name is Paul Carson, and I am a training and development specialist here in the pharmacy department at CareOregon. And it's our pleasure to host this ongoing series of education sessions for a primary care audience and the people who interact with our members here at CareOregon. Today's session is called Equity and Medications: Cultural Challenges Impacting the Medication Experience. We have several of these sessions peppered throughout the year. If you look on the screen here, you'll see that we do have upcoming sessions over the next 2 months before we wrap up 2022. We have a session on November 17th about creating a gender affirming environment, along with updates in hormone therapy. And to close things out on December 8th, we're going to have a comprehensive and enlightening review of pharmacy benefits, something there's always a lot of confusion regarding. And we've had a lot of folks ask for a little bit more clarity and a nice refresher, as well as an update on pharmacy benefits, because it can seem like another dimension to folks sometimes. So we'll be presenting that for folks at the early part of December as well. Real quickly, I would like to make sure everyone knows you will be getting a copy of these slides after the session today. So that slide deck will contain these links to enroll. So you don't have to worry about going around and hunting for those things there. So we'll have all those ready for you. And then there'll also be a link to our main program webpage where you can explore and find recorded videos of past sessions like this one. Great. Let me give you a brief overview of what the agenda is going to look like this morning. We're going to have a brief introductory segment from one of our pharmacists here at CareOregon. And then we're going to have some guest presenters from North by Northeast Community Health Center and a presentation from a pharmacist providing different perspectives on our content here today. But a large percentage of what we're doing here is less didactic this morning and more exploratory, where we're trying to learn from folks who are interacting with our members what they are seeing in terms of how they interact with medications. So we're going to have a couple of different panel discussions that should be really lively and interesting. We're going to begin with a focused panel discussions with some of our community health workers, and then we're going to bring in other clinicians and health resilience specialists to add to their voices to that discussion as well. If there's time left over at the end, we're going to try to collect as many questions using our chat as we can and provide a brief audience Q&A. So as questions occur to you today, folks, feel free to toss them into the chat function of this webinar, and we'll try to address as many of those as we can. Here are the learning objectives that we'll be reviewing here today. But I'm sure there's quite a few other things we'll be learning as well. And then folks are always asking us about how to get credit for attending here today. You want to make sure to hang out for the entire program, but we do have approval for CME and CEU hours, and as well as additional Oregon Board of Pharmacy hours as well. 2 hours for that. And at the end of the session, later today, I will send all enrolled attendees links where you can go ahead and attest that you are here, answer a brief survey question or two, and you're all done. And you'll get a certificate showing your attendance. Before I introduce our first guest and our first presenter here today, I just wanted to try to give a little bit more context about what it is that we are hoping to explore here today. Of all the things we've all experienced during the COVID-19 pandemic, all the things that pandemic has shown us, perhaps the most alarming are the racial disparities in public health. While life expectancy in America fell by 1.5 years in 2020, that's the lowest drop since the Second World War, by the way. It fell far greater for Black and Hispanic Americans, who lost 3 years of average life expectancy. We all know the social determinants of health: access to healthy food, safe housing, clean air, exist on top of a system that's rife with racial inequities. Racism itself is a public health crisis and a potent determinant of health in these United States. So are chronic disease and medications. We see in some communities of color there are veritable pharmacy deserts. Prescription drug costs are higher than they've ever been. Our healthcare institutions can also foster unconscious or implicit bias towards our patients, sometimes giving rise to false assumptions about adherence or tolerance, or even warranting medical therapies from blood thinners to pain medications. So we know medications play a role in these inequities, but how much do we know? We're beginning to hear a term emerging called pharmacoequity. It's an evolution in health systems where all patients, regardless of race, class, or availability of resources, have access to high quality, evidence based medical therapy. That sounds great. How do we get there? Those are some of the questions driving our exploration here today. So we're going to go ahead and begin with our program. And to start things off with our first segment, I would like to introduce Dr. Oyinda Osibanjo. Oyinda is a senior pharmacy clinical care coordinator here at CareOregon, and she is passionate about exploring opportunities to improve the quality of care for low income and underserved populations using her doctoral training in public health as well as her clinical experience. Her goal is to apply her tremendous wealth of knowledge, skills, and very unique perspective to design, develop, and implement innovative strategies that contribute to improving health outcomes for the Medicaid and Medicare populations. It's my great pleasure to welcome Oyinda Osibanjo.
Thank you so much, Paul, for that amazing introduction. I see I'm just smiling. But I feel it's a privilege to be here with you all today. And I want to say welcome to you all to this MedSed on equity and medications and focusing on our culturally diverse population and the challenges that they experience. As Paul has said, I am Oyinda Osibanjo. I am a senior pharmacist at CareOregon, and I'm super excited to be here today. So my goal here today is to set the stage for our MedEd, and the goal is to help you understand why are we here? Why are we focusing on our culturally diverse population? And first, I want to help you understand that based on the Census Bureau projections, one of the key reasons why we're focusing on our culturally diverse population is that by 2044, more than half of all Americans are actually projected to belong to a racial or ethnic minority group. And that is important for us as healthcare providers, which shows that we need to be equipped to ensure we provide that culturally appropriate care for our racial and ethnic minority populations. But more than that, most importantly, we have overwhelming data that shows that health disparities exist among our racial and ethnic minority groups. And this is evident in the poor quality of care, the higher rates of chronic health conditions, and we're even seeing lower medication use among this population. And in my next slides, what I'm going to share with you is data providing you with a bit of insight into that the disparities in quality of care for our racial and ethnic minority groups, the higher chronic health conditions that exist within this racial and ethnic minority groups. And then we're going to do a deep dive into the challenges associated with lower medication use for our racial and ethnic minority groups. First, this data pulls disparities and quality of care. And the data is actually from the 2021 National Healthcare Quality and Disparities Report. This data actually pulled quality of care in the area of person-centered care, which could focus on measures that highlight and accesses patient-centered care, patient safety, affordable care, effective treatment, and healthy living. And so you see those N stands for the number of measures that were used to assess each of these quality measures. What I want you to understand is that this data was actually compared to the white population to understand the disparities that exist among the racial and ethnic minority groups. And so what you're seeing is the green highlights if the it, if the care was much better for the white population, if it was better. The yellow highlights if it's the same, and the Red highlights if it was worse. So based on this, this actually highlights for the Black or African American population, and quality of care was actually better for the Black populations than the white population on only 11% of all quality measures. In fact, quality was better for the white population than the Black population on 43% of all quality measures. For the American, Indian, and Alaskan Native population, it shows that this group experienced worse quality of care compared to the white population for 40% of all quality measures, and in particular, 63% of all person-centered and person-centered care measures. For the Asian population experienced worse quality of care than the white population for 28% of all quality measures for the most recent data year in this study. For the Hispanic or Latino population, it showed a worse quality of care compared to the non-Hispanic and white groups for 36% of all quality measure. And lastly, for the Native Hawaiian and Pacific Islander population, this group experienced worse quality of care compared with the white population on 28% of all quality measures. And with this also comes that disparities in chronic health conditions. And based on the data from CDC as of 2020 and the US Department of Health and Human Services Office of Minority Health, this data was actually pulled from these sources. And what this data is showing that racial and ethnic minority groups experience higher rates of chronic health conditions than the white population. In fact, the data shows that 42% of African American adults over the age of 20 are diagnosed with hypertension compared with 28.7% of white adults over the age of 20. 21.5% of Hispanic adults over the age of 20 have been diagnosed with diabetes, compared with 13% of white adults over the age of 20. For the Asian American population, 40% of this population are actually more likely to be diagnosed with diabetes than non-Hispanic white Americans. And lastly, 80% of Native Hawaiians and Pacific Islanders were more likely to be obese compared with non-Hispanic whites in 2016. And you see, with higher rates of chronic health conditions among the racial and ethnic minority groups comes that need to treat with medications to ensure we have improved health outcomes. However, the data shows that disparities also exist in our racial and ethnic minority groups. In fact, the data shows that lower medication use for treatment of chronic disease is much, in fact, disproportionately higher among our racial and ethnic minority populations. And for the purpose of this method, actually step back to see how can we view these challenges in terms of medication and equity. And one of the key things that we focused on is to identify it from the healthcare provider lens and the member lens in terms of provider prescribing and dispensing, looking at healthcare provider communication and bias and cultural awareness. And from the members' lens, looking at the degree of personal health literacy. Are they able to understand the utilization of medication? And I want you to understand that we are not living in a bubble, assuming that this is going to solve all the problems. But one thing is important, that all these factors can actually be in the purview of control of us as healthcare providers. So first, we're going to look at healthcare provider communication and bias. You see, studies have shown that healthcare provider communication patterns differ between the white patients and patients of color. A particular study was conducted using audio recording, and what this study showed was that for primary care visits, when the research was conducted was that for Black patients, when they went into for their primary care visits, it was actually characterized by more verbal dominance, statements of direction, fewer attempts for that patient-centered communication compared to visits with whites. And that is something that has been shown in data over time. But also, we're seeing that bias, healthcare provider bias, may actually contribute to lower medication use. You see, studies have shown actually that patients who experience bias or discrimination from a healthcare provider were actually less likely to use their medications that was recommended by their healthcare provider. And I want to stop here and just say this. None of us, and I say this with clarity, none of us is immune to bias, including myself. But what is important, whether conscious or unconscious bias, is that we are aware of this bias and we are able to address it. And you see, that leads me to that next topic on cultural awareness. You see, as healthcare providers, cultural awareness implies that one, we recognize and accept our own cultural background that is unique. And we also understand that the perception of cultural differences in others. And we appreciate that our personal views potentially might influence our cultural perspective, personal prejudice, and personal values. And I just want to stop here and share my own personal journey. You see, I am an African woman born in Nigeria, grew up in Nigeria, and I want to say that until I came and I did my graduate study in Oregon State University as a doctoral graduate, I had to teach a pre-med class. And one of the key areas we teach is social determinants of health. And one of the key curriculums was to actually use a video to help our students, my students, understand the social determinants of health. And this documentary was 13th. It was actually on Netflix. We had to give them access. So they had to watch the documentary. And this documentary focused on the racial inequity that exists in the United States associated with the African American population. And until I watched that video, I did not appreciate the challenges associated with the African American population. So, though I am a Black woman from Nigeria, looks like an African American woman in America, my experience are two totally different experiences. And that instilled in me what is called cultural sensitivity. I watched the 13th documentary and I cried. And it was a very heavy class because they had to write their reports. But my point in all this is that it increased in me a level of sensitivity when I provided direct patient care for my various patients and understand that my experience is not the same as theirs. And for us as healthcare providers, cultural awareness will help us lead to cultural sensitivity. You see, cultural sensitivity makes us culturally aware, helps us to respect and accept cultural differences and diversity. And I want to tell you that it's not magic. It doesn't happen with just one method. It's intentional. It's taking time to learn other people's culture. It's making that effort to understand that you might not even understand where they're coming from and taking time for them to even teach you their own culture. And I just want to say it's a continuous journey. Now, we're going to go to the members' perspective in terms of the challenges we're talking about. And what I wanted to just focus on here, and like I said, this is not going to address the whole problem, but is in our purview of control. And what I want to focus on here is the patient's degree of personal health literacy. And you see, based on the Healthy People 2030 definition, personal health literacy is the degree to which an individual has the ability to find, and I want to emphasize that word ability, to find, to understand, and use information and services to inform health related decisions and actions for themselves and others. And the reason why I emphasize that word ability is because I'm going to share a study with you. You see, this study focused on culturally diverse populations. In fact, about 66.6% of this study were African Americans. And based on this study, they identified that 29.5% were reading at or below sixth grade level, which is considered low health literacy, low literacy. 31.1% were reading at the seventh to eighth grade level, considered a marginal literacy, and 52% did not graduate from high school or receive a graduate equivalency diploma, which is considered the GED. And why am I highlighting this is that when an individual needs to have that degree, personal health literacy, they need to have that ability. And you see, low health literacy is strongly associated with low literacy is strongly associated with low health literacy because it limits the ability to be able to find, understand, and use health related information, even for themselves and others. Because studies have shown that low literacy has a potential to impair comprehension. So, a study was conducted again, and this time they focused on adults with literacy below sixth grade level. And what was done was they provided instruction of take two tablets by mouth twice daily. And awesome, 70.7% of patients with low literacy correctly stated these instructions. However, 65.3% could not demonstrate the number of pills to be taken. And so you're seeing that low literacy, low literacy is will ultimately lead to low health literacy. And low health literacy results in medication error, hospital readmissions, low lack of preventative care, increased use of emergency rooms, and ultimately will be experiencing poorer health outcomes from this population. And that's why we're here today to have this conversation. That is why we're here today to look at how can we support our culturally diverse population. This is going to be my last slide, but as I share the slide, Dr. Mason and I is not here today. He's been amazing through our work. Dr. Mason is actually our Chief Equity, Diversity and Inclusion Officer for CareOregon. And as I was developing the slides, I had conversations with him and he said, Oyinda, we have to be careful as we begin to emphasize our culturally diverse population. We need to also emphasize one thing: health literacy universal precautions. And that is simply assuming that all patients may have difficulty comprehending health information and accessing health services. And that introducing health literacy universal precautions into our healthcare system helps us to minimize that risk of miscommunication by simplifying communication for all patients and confirming comprehension for all patients. You see, I strongly believe that as healthcare providers, our responsibility is to provide clear communication to our patients. I believe that is part of quality of care. And I hope that as we continue this conversation, that we'll be able to have opportunities to learn from one another and provide that support and best practices from one another. So I really want to thank you, and I'm excited to for this medset. So I'm going to pass it on right now to Paul Carson. Thank you, everyone.
Thank you, Oyinda. You are unbelievable. Wow, that was really phenomenal.